Finally. Thank you so much, sir.
How are you?
Fine, thank you. It's a pleasure to meet you.
Sure.
And it's a real pleasure to have you here answering our questions. I must say that when we got word that you'd accepted to have, to be present today and to answer our questions and the questions all the other Lagosians want to ask you, we were really, really quite honored. So thank you for your time, Honourable Commissioner.
Not at all.
Okay, I'm going to dive right into it. And I think, we'll start just by talking about the pandemic and how Lagos State has responded to it. And firstly, honestly, I really just must give kudos to your administration and the entire, people of Lagos State, because the statistics we have are quite impressive when it's compared to other parts of the world. We see what's happening in the USA now, and we know those are really, horrible stories. We see their graphs on the news going higher and higher every day. We see the kind of fatalities that they have. And somehow, people say it's God, maybe we're blessed, it's luck, but I want to believe that it's also through the efforts of the people like yourself and the formidable team that we have on ground that have helped to keep our fatalities at such low numbers. I'm going to reel out some statistics if you don't mind, because I want people to get a real sense of what it is that we've been able to achieve. So in Nigeria, we have over 41,000 cases, only 860 fatalities, and that's at a rate, if you look at our total population, it's about 4 fatalities per 1 million people. In the United States, they have 454 fatalities per 1 million people. And even Ghana, yes, they have a lower population than us, but they seem to have a higher rate of fatalities as well. And they have a fatality of about 5 per 1 million people. And, in Nigeria, saying we're only 4 fatalities per 1 million people is something that I think we have to give kudos to ourselves for. If we look at the statistics for Lagos State, well, we have just about 194 deaths. And you look at a population of Lagos State that is running into over 14 million people. I think it's really, really quite commendable that we've been able to keep our numbers of fatalities down the way that we have. So what will you say has contributed to this? Why do we seem to have gotten off fairly, better off than many other countries and states, even other states in Nigeria?
Well, the data I have that I'm confident about talking around is the data from Lagos. Can you hear me?
Yes, very clearly, sir.
Okay, the data I have is Lagos data, so I can only speak with any authority on Lagos data. And as far as we're concerned, it's, after we had the Ebola experience in 2014, and subsequently we've had a number of biosecurity threats to the state. We've been preparing consistently, knowing full well that this kind of event could very well be around the corner. And when you look at global biosecurity data, we seem to be living in an era of what's called emerging infectious diseases. And those are, another name for that is zoonotic events. So a zoonotic event is when a pathogen of an unknown pathogen is able to move from the ecosystem into the human population and establish an illness that is transmissible. So we're seeing more and more of these events much more frequently than we've ever seen before. And the WHO and certain other international agencies that specialize in this kind of phenomenon have been predicting that we're going to see one wave after another, and therefore we need to build what we call biosecurity threat resilience. Having been through Ebola in Lagos, and because of the unusual demographic profile of Lagos, Lagos is a hyperdense metropolis, and therefore is extremely vulnerable to airborne or waterborne transmission.
Yeah.
And so we knew that something was going to happen. We didn't know when or what. And so we started to prepare almost 5 years ago for this kind of event. So when we saw what was happening in Wuhan, in China, and we saw that it was beginning to become a global problem, it was moving from country to country. And you see, the other thing is that nowadays there's so much international travel that it's so easy to be in one part of the world now, and in 6 or 8 hours you're in another part of the world. And global air travel is so cheap and easy now that, you know, a pathogen can easily move around the world. So we saw it creeping around. We first thought we might get an entry into Nigeria from China because we have a lot of trade going on between China and Nigeria. But that didn't happen. But the moment it hit Europe, we knew that something was going to happen. So we were already preparing before Wuhan. When Wuhan started, we continued to prepare. We accelerated our preparation. And then the moment it hit the Middle East and Europe, then we went a little bit ballistic in terms of preparation. So the first 3 months after our index case, we managed to hold the transmission within Lagos State as tight as possible. Mm-hmm. And that did two things for us. Of course, it delayed the movement of the virus within the community, what we call community transmission. Mm-hmm. But it also gave us a bit of time. And that time was very critical because in that time we could ramp up infrastructure, we could ramp up manpower, we could set processes in place, we could mobilize resources. But critically, it's very important to buy time during a biosecurity threat, because what that does is you can learn about a new pandemic. So they call it the novel coronavirus. So novel means it's new. Mm-hmm. If it's new, it means we don't know anything about it. We don't know how it causes disease. We don't have treatment. We don't have vaccine. So the longer you are able to hold up or hold off your outbreak in your country or in your environment, the more you can learn from other people's experiences. And science does move very fast nowadays. So we've spent a lot of time scouring the international press, scientific press, looking for evidence around how this virus causes disease, how we can manage it, what's right, what's wrong, what have other people tried, what worked, what didn't work. So that's the critical nature of buying time during a dangerous pathogenic outbreak like this COVID-19. So in a nutshell, that's where we are at the moment.
Okay, excellent. Now, I'm going to talk about three things very quickly, one after each other. The first is testing, tracing, and the treatment. And in each of these three areas, I want you to tell us more about the strategy in Lagos State around each of these three, and what kind of capacity do we have, and what are your plans for the future? I mean, do you in Lagos State in terms of infections? Some people are beginning to say that there is no capacity in the isolation centers anymore. We are aware that there are other, private institutions now that have capacity to test. But is this adequate? Is this accessible? How many Lagosians will be able to afford it? In your own kitty, in Lagos State now, the public facilities that offer testing, are they adequately resourced? Are we running out of testing materials? Do we have enough? So if you can just talk us through these three areas. Tracing, we haven't really heard a lot about in recent times. Is that still happening? Do we have the required level of resources for tracing? And I mean, what is that bringing to the table for you as you manage this pandemic in Lagos State?
So thanks. Those are really important questions. Testing, treatment, and contact tracing. So like I said, we built up our capacity for testing. So we developed what's called a biosafety laboratory level 3. So there are 4 levels of biosafety laboratories, 1, 2, 3, and 4. So 1 and 2 are the average type of laboratory you would find in a general hospital or in a specialist hospital. or if you go to any of the private laboratories, they're usually operating at a safety level of 1 or 2.
Okay.
When you're dealing with a dangerous pathogen, you have to move into what's called a biosafety level 3.
Mm-hmm.
And then in a biosafety level 4 is where you deal with extremely lethal pathogens. Pathogens that you can't even risk the opportunity for them to escape out of the laboratory. So we don't have a 4, but we built a 3. And a 3 is about the highest level that we have in Nigeria and even across West Africa. It's a very sophisticated laboratory. It's where you can test and manipulate a dangerous pathogen like COVID-19. So we already had that on ground. We had trained the personnel. We had a whole team. They'd been trained in Nigeria. They've been trained abroad. They've been going through procedures, practices, simulations. Every month we were simulating this kind of scenario for about 3 years. So the team was ready. So when COVID came, the infrastructure was on ground, but it was a new pathogen. So you can't test for a new pathogen until you understand its genetic code. So we had to wait. We had to wait for the global community, the international community, to give us the code of the virus, what we call the genetic code. So as soon as we got the genetic code, we were able to then you perform the test experiment. So we were ready for testing. Of course, we didn't have huge capacity at the beginning, but we soon ramped up our capacity, and the Nigerian Center for Disease Control, great assistance to the state. We developed 2 or 3 other laboratories. And so right from the beginning, we had reasonable testing capacity, which is why you see Lagos testing by far more than any other state in the country. Treatment. So at the beginning of the outbreak, the treatment was anybody that was positive needed to be isolated so that we could delay what I described earlier on by delaying the phase of community transmission. So if you are positive, we try and find everybody that's had contact with you. We test them, we isolate them, and that way we kept the graph extremely flat for the first 3 months. So we already had isolation centers, but we built a lot more. And right now we have 7, and with a lot of isolation capacity. So we have extra capacity in our isolation facilities. So even if we had a sudden surge of cases, we can absorb all of them.
Sorry, Honourable Commissioner. In recent times, people say that the capacity for admissions into the isolation centers have been stretched to the limit, and that people who are even admitted are beginning to be discharged before they're tested negative. Have we reached capacity at the isolation centers now?
Okay, so with an outbreak like this, it's very dynamic. The situation is evolving every day. So there was a point where we wanted to isolate everybody, to contain the virus. If we carried on like that, we would have, of course, exhausted our isolation capacity. Now, even in America or England, they couldn't isolate everybody. You can only isolate a certain number of people.
Sure.
But in that time frame, we had also been studying the virus and the way it works in Lagos. And we discovered that there are about 4 categories. There's people that catch the virus and are completely asymptomatic. They don't even know they have the infection. There are people that catch it and have a mild illness, so they just have a bit of tiredness and weakness, maybe a slight fever, some body pains. And there's a 4th category. The 3rd category is moderate, where they definitely know something is wrong. They're weak, they've lost their appetite, they can't taste food, they have a prolonged period of fever, and then there's the severe, where it starts to affect your organs. So once we understood how to stratify people into different categories, we realized that we didn't need to isolate everybody in our isolation centers, and we could manage asymptomatic to mild in what we call the transition to home-based care. And because as our testing was increasing, we were diagnosing almost between 150 and 200 every day. And if we increased our testing, we will find more people. But what was important at that point was, as we expanded our testing, to be able to immediately define what your clinical course was going to be like. So if you are mild or asymptomatic, we would keep you at home and give you instructions about how to manage yourself at home, which is exactly what happened in Europe and America and elsewhere. But if you are severe or moderate, we would rather keep you in the isolation center. The good thing about it is that majority of people in Lagos had the asymptomatic to mild disease profile. And then about 30% had the moderate to severe. So we are reserving our isolation center capacity for the moderate to severe because they need closer medical monitoring and closer medical attention, and a lot of them would require oxygen. And we are managing people with asymptomatic to mild at home. So once we stratified like that, we realized it was using modern technology like telemedicine and helplines and decentralizing management to the primary healthcare level. We're able to manage people at home. There's a lot of information out there. People are already quite informed about corona. And then, but we were particularly interested in people who are moderate to severe because many of them could deteriorate to respiratory failure.
Indeed.
So we changed our policy completely from the beginning to about a month ago when we started stratifying people into different categories and building more intensive high care in our isolations and just palliative management for home-based care. Excellent. So your last question was around contact tracing. Yes, contact tracing is very important. With every positive person we get, we are able to find a network of people around them. We offer them testing. We guide them, and if you know you've been in contact with somebody that's positive, then we offer you testing free of charge. And if you're positive and you fall into mild to asymptomatic, then we manage you at home. If you are positive and you're feeling unwell and not likely to do well with home-based care, then we move you into the isolation facilities. So as the numbers expand, of course, the work increases, but we have a lot of volunteers that we've trained, and people are getting a little bit more adept at managing COVID-19. So we've learned, the learning curve has been extremely steep for us.
Excellent. So, Honourable Commissioner, some time back, we became aware that some private facilities were also accredited to provide testing. And I think there are about maybe 7 or 8 in Lagos that have been such, that were accredited in that manner. What has the uptake been? What are the statistics looking like from the data that you see from these facilities? Are you satisfied that it was the right move for Lagos State to have done at that time? And is there, thought around maybe even further expanding it? Is the cost of testing going to go down from the private centers? These are all the kind of questions that we get asked all the time, that, it's to get a free testing, you wait such a long time. If you go private, it's about 50,000, 45,000 naira in some instances. Can it come down cheaper, perhaps? Is there something being done about that? Can there be many of them more than what we have now? Because some parts of the states have and then some others don't have.
Okay, so regarding testing, which is different from managing patients. So let me deal with testing first. If you're trying to test as many people as possible, and you want to get a better understanding of what the virus is doing in your environment, it's best to test as, go push your testing into the thousands and if possible into the millions.
Yeah.
Now, we must remember we're still a low to middle income country, and each of these tests is very expensive. So we invited the private sector into partnership with government because two things were happening. The first thing is that there's a difference between you need to be tested and you want to be tested.
True.
So if you need to be tested, it's because you're not feeling well or you've had a very close contact with somebody who has been established to have COVID. So that is a public health response. That is the ambit of the government to be able to test people that need to be tested. But in the mix are a whole bunch of people that want to be tested for peace of mind or for corporate responsibilities. They want to go back to work or they want to travel. Now, that's not part of a public health response. So we had to make a distinction between need to test and want to test. We had lots of people coming for testing who just wanted peace of mind. Now, we don't test for peace of mind, neither do we have a treatment for peace of mind. So it's not part of the response. So we thought, okay, let's invite the private sector and they can cater for the want to test, for your peace of mind, or you're a big company, you want your staff to go back to work, you want to travel or things like that, you can go for want to test. The other thing that was happening was that private sector was beginning to gain capacity to do the test because it's a very complicated test. And we were finding that the testing tariffs were all over the place. Some people were charging up to 300,000 naira per test. Some were 200, some were 100, some were 80. And, it's the duty of government to be a public protector. Sure. So it was important for us to understand really what the cost of the test is, to make it illegal for you to test outside of government, because this is not just malaria or something like that. This is a public health threat, and therefore all tests must be carried out under the jurisdiction of government. Government must know about every positive person in Lagos State. Government must have access to that sample and data, and government must be able to understand what's happening to the outbreak in this environment. If private sector was testing, we wouldn't have that data. Number one, we wouldn't know what to do with the patients. The patients would eventually come, some of them would come to us, and we would not have the evidence that they're positive. And secondly, we needed to do something about regulating the price of testing so that the public were not exploited. So what we did was to form a consortium of private laboratories to empower them to make sure that they were testing in a safe environment, and to, of course, make sure that the testing was accurate, because the test for COVID-19 is a very complicated test. It's what we call a PCR, molecular biology test. It's not done in any old laboratory. It's a very precise science, and it requires a lot of expertise and a very exact environment so that the staff don't get infected and that you're getting the right results all the time. So we had to make sure that the labs that put themselves forward to be part of the consortium actually had the capacity, one, to do the test, two, that the test would be accurate, and three, that they would not be putting themselves at risk while doing the test. Because under this country...
Sorry, Honourable Commissioner, I was going to say also to ensure that the data was available to you virtually real time as soon as they tested people, that you had access.
Absolutely, because without data, it's data that drives government policy. Yeah. So we need to know exactly what's going on in the state. So those are the reasons why we formed a consortium of private laboratories. We regulated them. We made sure we did quality assurance on them. We ensured they were doing the right thing. We ensured they were protected. And we were able to, in a way, manage the tariffs.
Excellent.
So now a lot of want to test people are going into the private sector to have their tests. It's not any faster than the state, because the state has incredible capacity at the moment. But
Oh, wow.
it might be more comfortable for you to go and sit in an air-conditioned private waiting room or things like that, or if you want to pay a bit more for them to come to your house to test. But the state also goes to your house to test.
Yeah.
And let me just emphasize that testing in the state is absolutely free.
Yeah.
There is no cost to COVID-19 management under the state.
Yeah.
So I don't know if you want to talk about the private sector care,
Yeah.
or maybe
I
we
was
can
going
come
to
to that later.
Yeah, no, I was going to move directly to that now to say that, well, to the best of my knowledge, I think only 3 facilities in Lagos have been accredited for private sector care management for COVID-19. And I'm wondering, really, as many other people, is this adequate? I understand, though, the strategy that Lagos State has now, which is what you've, so clearly articulated this afternoon about the asymptomatic and the mild symptoms being managed at home. But I have a question for you there. So for the asymptomatic and the mild symptom people who are basically being managed at home, what resources do they have available? Where can they call into? Where can they find information on how to take care of themselves? And if those are also maybe having doctors come treat them, or doctors offer them some kind of support, is that being monitored in any way? And then I'll move to the actual healthcare facilities where the more critically ill people are being admitted to, in addition to the Lagos State isolation centers. So the people that are mild, the people who are at home, who don't necessarily need oxygen or any of this, sort of high level management yet, but really are still quite ill and are infectious. The state they're at the stage where they can infect other people. Does Lagos State have a handle on how those people are being treated and the protocols around their treatment? Do they know? Do the doctors seeing them know what to administer and how to care for them? And where will the doctor or the patient find such resources to assist?
Okay, so those are the parameters around what we call home-based care. So we've put out a very careful strategy whereby if you are tested positive and we call you with your results, we offer you isolation. If you decline that offer, we just make sure that it's not because of the stigma around our isolation facilities that you're declining care, but that you are truly mild or asymptomatic and believe you can manage yourself at home, and that your home environment is adequate for you to be isolated. So that happens over the phone at the first contact with the positive patient. Once we release the results to you, if you're positive, we ask you these kinds of questions, and then we follow you up regularly with both a follow-up team, a contact tracing team, and a psychosocial team. So
Wow.
because we think that a lot of people will suffer a significant amount of psychological stress as a result of the giving you the result.
Yeah. Yeah.
And also people around you, your family members suddenly may go into a state of panic. So there's a psychosocial support, there's a group, they have group Zoom meetings. You're invited to join Zoom meetings, and you can hear other people's testimonies around how they took their diagnosis, how they're managing at home. And then you also get advice on what we call simple palliative treatment. In other words, rest, vitamins, anti-fever medication, something for pain relief, and a balanced diet and good hydration. We're also introducing eco-telemed, which is a form of telemedicine. So you'll be able to receive consultations, and that's free of charge. And then we have a helpline. So outside of us calling you, you can call us. And then we have people in the primary healthcare level, community health extension workers that can visit you at home. So there are multiple layers of monitoring. And if you're mild or asymptomatic, you don't really need much treatment other than rest, good hydration, some antipyrexials and vitamins, and you'll overcome the infection yourself.
Okay.
So that's how we monitor what's going on. And we've done quality assurance on people at home. We randomly go through our list, and I've done it myself. You call people, maybe every 10th person on the line list, and you say, you ask them how they're doing, are they satisfied with the care they're getting? Most of the time they're satisfied. Sometimes we drop the ball. That's only natural.
Yeah.
But we do have a helpline, so if people feel that they're not getting enough information, then, but there's so much information out there right now that the government has put out, that we've put out. So if you're mild to moderate, some people just feel that they can manage this thing themselves.
Yeah.
If the private sector family medicine practitioners are managing or helping to manage such patients, we don't really have information on that. We are just working on that policy shift as well, where we are going to make sure that private practice family medicine practitioners are well informed about what they can do or how they can be engaged in the process without putting themselves at risk.
Yeah, we think that's quite important as well, and not just not to put themselves at risk, but also to feed back into the data that you have about what is happening in the field, so that the management and care and what has been learned from that then goes back into this huge body of knowledge and information that helps to form your policies and your strategies going forward. So talk about the private health facilities that have been accredited, and the understanding is that they've been accredited to treat the really critically ill patients of COVID-19. Can you talk to us about this? Why only 3, for instance? Surely do we not need more than 3? Or, there was very careful thought put into why just 3 at the moment, and can we just understand your thinking around that?
Okay, so we as government, we can't force anybody to participate in COVID-19. We engaged the Association of Medical Practitioners, and there are many associations, and we opened the opportunity for them to participate. We did that for 2 reasons. The first reason was we weren't sure whether we were going to completely exhaust state facilities. So we wanted to make sure that we had some kind of backup from the private sector. But we also didn't want the private sector to get into the management of COVID without proper accreditation and understanding of what it requires to manage a COVID patient, particularly the moderate to severe cases that need critical attention. So we opened up the opportunity for partnering, and a number of people came forward. Remember, there's still a lot of anxiety around COVID-19. There's a lot of fear. There's a lot of uncertainty and unknown factors. So not many people or not many institutions had the courage to come forward and say, I want to subject my facility to COVID-19. Remember, it will come with a stigma. Yes. You could actually lose business if you are labeled as a place where people come for COVID management.
It's a double
we found, it is. So what we found is that private sector that operate more than 2 or 3 facilities would reserve maybe 1 facility for non-COVID management and would put another facility for purely COVID management. So that way they didn't mix up the management of COVID and therefore didn't drive away business.
Yeah.
So that's why we only have 3 at the moment, but we have another 4 or 5 in the pipeline that have gone through validation and accreditation, and we're just doing the final touches to giving them their certification for managing COVID. So managing COVID requires 3 things. It requires alteration to your infrastructure. It requires infection prevention control management. It requires training of your staff. And then at the end of the day, it also requires your ability to give us the data around your patient management. So these private facilities had to go through a lot to get their facilities approved for COVID-19 management. So for example, we just had to make sure that, first of all, they're not putting other patients at risk, they're not putting their staff at risk, and that they have the right infrastructure for managing COVID, because COVID is a biosecurity compliance hazard. So you need to change the way you move in and out of a facility. You know, the doctors put on PPE to go in. There has to be a place for them to come out, and to come out safely and to decontaminate. And then, you know, you get a lot of patients who have typical COVID-19 features, but they don't have a positive test.
So, that's Honourable Commissioner, I'm sorry to interrupt, but I've had a friend that was like that. And it's really quite puzzling. I mean, is there a scientific medical explanation for that? Because in every other respect, you know, it looks like COVID. We were all sure, you know, that, you know, he had got infected with COVID, he had breathing difficulties, he had all the symptoms, he even complained about taste and smell, but it tested negative. I mean, I'm taking us a bit off the topic right now, but I'm sure that many people listening to who've encountered this. Do you see it often, and how do you handle such cases?
So if you don't, I mean, the answer to that is quite simple. If you suddenly got unwell and you have not tested, but you're deteriorating, you will find yourself going to a hospital. So you arrive at a hospital with typical COVID-19 features, and what the hospital doesn't know what to do with you because you don't have a test result. So isolation is divided into two. We call it isolation 1 and isolation 2. Isolation 1 is for people who have typical features of COVID-19, but we've not got a positive test, or they've not been tested. So you put them in isolation 1. Now, isolation 1 is completely different from isolation 2. Isolation 2 is for people who are confirmed COVID. So their management is usually in open wards. It's more communal management. You know, the patients can see each other, they can interact with each other. But in isolation 1, you have to go into your own self-contained, managed cubicle that doesn't allow you. So if you have COVID symptoms, it doesn't mean you have COVID. There are about 100 other viruses that can give you exactly the same clinical features. So if you don't have COVID, but you have COVID features, and we put you in a ward where there are other COVID positive people, then you will have your original infection plus
I'm dead.
plus COVID. So you will get infected with something that you were not infected with before you came into the hospital. So, I mean, and that could be a very dangerous situation. So that's why I talk about the infrastructure. The layout of an isolation facility 1 and 2 is a very complex thing. And the private hospitals that are going into case management of COVID, they had to go through an elaborate process of modifying the actual physical infrastructure of their buildings to make them biosecurity compliant. So that's the reason. Now, when you're in isolation 1, we manage you as COVID, but we do the test. And then if you're positive, then we'll move you to isolation 2. If you're negative, then we'll discharge you and manage you as a case of another virus that is causing COVID-like symptoms, which is not COVID.
Excellent, excellent. I'm going to move on very quickly to what I call myths and therapies. And there are all kinds of myths out there. But today I just want you to tell us what is real, what is not. What works, what doesn't work. Do I start with the most controversial one?
Go ahead.
What's that famous Trump, medicine that he keeps, hydrochloroquine? What's it called again? Yeah, I mean, what's the deal on that? Does it work? Does it not work? I hear people who suffer from lupus who used to be able to buy for about 7,000 naira per packet are now having to buy for 48,000 naira because it's just simply so scarce. And people might be unaware they're actually depriving other people who are genuinely ill and in need of this medication from being able to have access to it and being able to afford it. But is it worthwhile stockpiling even when you've not tested positive? Does it work? I mean, what are people doing? Are people meant to treat themselves with it at home, even if it does work? What are your thoughts? There's quite a lot of stories going on around this course of treatment.
Okay, so it's called hydroxychloroquine or chloroquine. So hydroxychloroquine is an analog of chloroquine, which is, as you know, what we used to use for treating malaria long time ago until the malaria parasites became resistant to chloroquine. So we stopped using it, but it's still a drug that we use for other things. Now, chloroquine works in two ways for malaria. Number one, it kills the parasite. But the other thing it does is it's an anti-inflammatory. Yeah. So it brings down the inflammation that is caused by an infection. So even if you take chloroquine, and that's why it's used for other things. So people use it for rheumatoid-like diseases because of its anti-inflammatory properties. So if you have any infection and you use chloroquine, it will kind of dampen down the inflammation around that infection without necessarily having an impact on the bug or on the pathogen that you're infected with. So is chloroquine useful or not, or hydroxychloroquine? You know, the truth is that we've not got any evidence. And nowadays we talk about evidence-based medicine. So it's not ad hoc. It's not I think, or I had an experience with 20 people. And, you know, evidence-based is very robust, is mathematical, and it's statistical. So you need a large number of people to be able to say categorically whether a drug works or not. I know we've all been exposed to this social media blast on hydroxychloroquine. We were about to start trials almost as far back as about 2.5 months to 3 months ago. We had all the protocols drawn up. We have all the drugs, and then the WHO said chloroquine is toxic and shouldn't be used. So that shut down our clinical trials until WHO reversed their statement. But having reversed their statement, the damage had been done. And so the funding organizations that usually come around to help develop trials were a little bit reluctant to get into a trial when WHO has said that chloroquine is dangerous. Now, we didn't believe that. We decided to carry on with our trial preparation. But of course, everybody's using, well, not everybody, a lot of people are using chloroquine. I can't tell you 100% whether it works. I know it has an effect. Whether it's curative or not, I can't tell you because we simply don't have the evidence. And if we were allowed to carry our trials out, maybe after 2 or 3 weeks or 4 weeks, we may be able to say categorically. Now, the other thing is that chloroquine is a cheap drug. It's what we call a repurposed drug. So it was originally designed to treat malaria, and then it was repurposed to treat inflammatory conditions like rheumatoid arthritis, and now we're going to repurpose it for COVID. So it's lost its what we call patents. So anybody can make chloroquine now, and therefore it's cheap. So there is a big controversy going on out there that the international pharmaceutical companies wanted to kill chloroquine so that we would only be using newly developed drugs, which of course are extremely expensive because they're still on patents. And so, you know, we're not sure what's going on out there, whether there is an agenda or not. You know, it's difficult to say. All I can say is at the end of the day, it's been hard for us to start our clinical trials because of all this controversy. And secondly, we don't have any evidence. In theory, it should work to some extent, but whether it's curative or not, I can't say. I know people that we've used it on that have done well, but I also know people that we've used it on that haven't done well, you know, who have progressed to severe and critical. So it's not a 100% drug, you know, and I wouldn't want to let the public think that that's the case. What is the case is we don't have evidence, and therefore I cannot tell you categorically that chloroquine is a definitive treatment.
Okay. I'll move on to the next one, vaccines. What is the latest in vaccines? Where do we stand as Nigeria at the moment? I mean, over the news, we hear in other parts of the world that vaccines have proceeded very, very quickly. They're now doing trials. I saw a lady on the news the other day who was the first human trial, recipient of the vaccine. Where do we stand as Nigeria? I mean, when is it going to get to us? Are there any that Nigeria is in any way, shape, or manner involved in? Are we going to be part of the trials that are being run? What do you have any news for us at all?
So vaccine development is a very exact science. Normally it takes about 3 or 4 years to get a vaccine through its production and to ensure that it's safe. So it goes through phase 1, it first goes through animal studies, then it goes through human studies, and the human studies are broken down into 3: phase 1, phase 2, phase 3. And even after phase 3, and it's been approved by a drug agency like the FDA or NAFDAC, it will still go through a process of about 1 or 2 years where after we've used the vaccine on the population, we're watching the population very carefully for post-vaccination symptoms or signs of complications. So, a vaccine is usually something that you inject. Once you've injected it, you can't take it back. And you don't know the long-term consequences of a new vaccine. It could stop you from catching that infection, but it could have other side effects or what we call collateral damage from using a vaccine. So the vaccines we use nowadays are really, the mumps, rubella, measles vaccines, chickenpox, and and hepatitis. These are vaccines that we've tested for decades. We know their safety profile. We know there's nothing wrong with using them. There's very little side effects to the vaccine. The benefit from using the vaccine far outweighs any risk. So there are 2 things here. First of all, we're collapsing the time to production of the vaccine. So instead of taking 3 years, we're trying to produce a vaccine in 6 to 9 months. Now that really, you bypass a lot of safety measures to be able to get there. And then if you do get it approved, you're still not sure whether if you start to vaccinate thousands and millions of people, if all of a sudden at 6 months there's a side effect that we didn't know about. Let's say it starts to cause kidney problems or starts to cause nerve problems. Well, you've vaccinated.
I remember many years ago, there was some new medicine that affected fetuses, and it was a scandal.
Thalidomide.
Yeah, thalidomide.
Yes. So now people were using thalidomide, and then all of a sudden we're discovering that pregnant women who used thalidomide produced children with no limbs. Yes, so that was 9 months. So that was 9 months after a new drug was released into the market. Now that caused a huge problem in the community. So this is exactly what I'm talking about. You inject a vaccine into thousands or millions of people, and then 9 months down the line, you find out that it's causing a nerve problem. Well, what are you going to do? You've used the vaccine to treat a public health crisis, and you've created a chronic illness, in a large number of your population down the road. So vaccines development is one thing, and vaccine rollout is another thing, and we just have to be careful. Do we produce vaccines in Nigeria? We've produced some before. Of course, along with many other things, we've let a few things slip, but I think this is an eye-opener for us that we need to get back to developing that kind of technology.
Yeah.
Will we participate in trials? Yes, why not? But, we just need to do a lot of community engagement before we do that, because, there's always these conspiracy theories that they're using Africa as an experimental ground. So we just have to prove to the public that any trial that goes on in Lagos is not a trial where people are saying, let's use Lagos as a guinea pig where, the trial is going on across the globe, from America to Europe to India to China, and Lagos is just part of an. Exactly, so that we don't fall. And, community engagement is a very, very, very important part of research in this kind of environment. You just have to make sure that your community are satisfied, your community are well informed, and your community accept that we want to be part of a global trial on developing a vaccine for COVID-19.
Thank you so much. We have barely 20 seconds left. Nigerians generally, but Lagosians in particular are non-compliant. Please, what are your final words to get Lagosians to simply wear their masks and practice social distances? Help me to put them scare in their hearts. Scare them a little.
So you know that they...
Hello, I'm so sorry. I didn't realize time had gone so quickly. And, everyone was waiting on what you had to say, because we're all getting a bit scared of seeing Lagosians going around with their masks on their chin, not even wearing at all, no social distancing. So please, what can you tell everyone so we all sit up?
Well, that's called non-pharmaceutical intervention. It's the responsibility of a socially conscientized community, a compliant community. So if you're saying that in Lagos we're not a compliant community, I don't know that I can agree with you, but all I can say is that we have to keep encouraging our people. They've been great up to now. I think Lagosians are well engaged, they're well informed. We still have some doubting Thomases out there, but by and large, I think that Lagosians are very engaged with the process. We've put a lot of information out there. They've been great at responding to some of the things we do. Yes, you drive around through the more crowded parts of Lagos and you see people throwing caution to the wind. I think you would find that anywhere in the world. All we can do is just try our best. You can't force people. We're not a military state, so we can't go around, I mean, if we had to, we had to, but at the moment, we live and let live.
Yeah, you seem to be very happy with the level of compliance we're seeing so far. And I must say that I'm quite reassured. The confidence you have has made me feel a lot better. And I'm also, very, very glad to see the level of engagement that Lagosians have with the issue, actually, and the kind of response we had when we started talking about this session on our social media handles. And I'd like to say once again, thank you very much for accepting our invitation to be here. And thank you to everyone who joined in and who sent their questions. And it was from their questions that I got to ask you all this interesting stuff that then, came out. So, Honourable Commissioner, we're very grateful. Thank you.
It's been a pleasure, and your questions have been very interesting and very insightful as well. Thank you for the opportunity.
Enjoy the rest of the holiday and Barka de Salah.
There is no holiday in COVID-19, after COVID-19.
Your family might be, getting a feel of this Salah celebration. You would be working, pouring over your data and all of that. But hey, around you, try and create some time for them today.
So my family are tired of COVID-19, so I can understand that.
Okay, sir. Have a nice evening.
All right.
Thank you.
Bye-bye.
Bye.